Thank you. Good afternoon. My name's Joanne Lord. I am only a health economist. I'm not a healthcare professional. I work at the University of Southampton. I just wanted to say I don't have any personal financial conflicts for this talk, but our group receives funding from NICE to conduct or to work within the Health Technology Assessment Programme. And I've previously worked within the Clinical Guidelines Programme at NICE, and before that within the Technology Assessments Programme at NICE. So I kind of feel fairly embedded within NICE processes. But of course I'm speaking for myself, I'm not speaking for NICE or the NIHR or any of our funders. I would also like to say that I'm not going to attempt to speak for Europe. I'm not even going to attempt to speak for the UK. My knowledge is fairly not limited within England, I would say. I'm sure there's people in the audience who know far more about how health systems and clinical guidelines programs work elsewhere in Europe. Okay, so I'm also starting, as you might expect, as a health economist from the position of there are resource constraints. And there are resource constraints in every healthcare system, no matter how rich or poor, no matter how the system is organised, public, private, insurance, publicly provided. That doesn't mean that, so costs matter, but costs clearly don't matter for every clinical guideline question. For some recommendations, they might save money. In others, it won't make a difference in terms of healthcare resources. But there will frequently, if not often or always, be questions within clinical guidelines that would require a change in the way that resources are used. So that means costs matter in clinical guidelines. However, it has been, and I think continues to be, contentious of the extent to which the people developing clinical practice guidelines want to be or are or should be responsible for taking account of the resource implications of their recommendations. And I think this was put quite nicely in this quote that from the Institute of Medicine report on clinical practice guidelines from way back in 1990. I think they were admirably honest about that this was a contentious issue and there was disagreement within the committee. And consequently, they put forward this kind of what they called a modest proposal that where clinical guideline developers weren't in a position to be able to include considerations of costs when making their decisions about what recommendations to make, that they could at least collect information or present information about the resource impact of their recommendations that then other people in the healthcare system, practitioners, managers, policymakers, patients could use when making decisions about how to use resources. Of course, there have been other views, so I've got a quote here from Alan Williams, notable health economist, who was putting the case rather more strongly, if you like, that there is an ethical requirement for when making recommendations to consider the harms as well as the benefits of recommendations. And some of those harms might include diverting resources from other uses. And therefore, you have a responsibility as a guideline developer to take account of that. And the other point that Alan Williams was making was about the importance of consideration of decisions made within clinical guidelines and in health technology assessments, and the importance of aligning the ways that decisions are made in those two sometimes very different systems. And of course, in for some clinical guideline developers, they do have a very clear remit that they should take account of resource considerations. And of course, NICE clinical guidelines, developers have always had the remit to consider the cost implications for the National Health Service alongside the health benefits and harms for the individual patients who are the subject of the guidance. And so there's a long tradition within NICE of trying to do that, and of course it's not always as easy as you might think, so I'll talk about some of the difficulties. So I think maybe that leads us with three kind of broad approaches to taking account of economics within guidelines. At the top, I've kind of illustrated, if you like, a traditional clinical guideline approach where the guideline developers take responsibility for weighing up the benefits and the harms for the individual patients who are the subjects of the guidance. And where there are downstream resource implications, it's then up to other parts of the health system to make those decisions, to weigh up whether it's worth funding the guideline recommendations and whether the benefit from doing that at a population level is worthwhile. And then secondly, we have the Institute of Medicine kind of modest proposal where the guideline developers might collate information about costs or resource implications and put that alongside the information about health benefits and harms that can then help to inform decisions by practitioners and policymakers and so on. And then at the bottom, this idea of the integrated approach where the guideline developers take explicit account of the balance of benefits and harms for the individuals and also the cost effectiveness at a population level, so where they have a formal remit to do that. So where guideline developers do want to think about cost implications, and I think whether that's a good thing or not, or whether that's appropriate or not, is going to depend on the context. In some situations, it's not going to be possible. Particularly, for example, if a guideline developer is making recommendations across a number of different healthcare systems with a number of different payers. So, for example, as in the United States, or if you're trying to develop international guidelines where there isn't a single payer, and therefore there isn't a single view on what the, if you like, the cost effectiveness threshold is or should be, or how those cost effectiveness decisions should be made. But if you are going to take account of it, there's this kind of broad distinction that was made by David Eddy between, if you like, the balance sheet approach, or for health economists, we'd quite often call it a cost-consequence analysis, where, if you like, you just put the cost information alongside the health benefit and harm information, and then it's a subjective, qualitative decision for the guideline makers as to which side of the line they want to fall. And contrasting that with a formalized decision analysis or economic evaluation with a quantitative weighing up of the costs and offsetting that across a quantitative summary of the net health impact, often, for example, in the form of a QALY or a DALY or some sort of composite measure of health impact. And obviously, if you're going to do that, you also need to know how you're going to make a decision about whether something is cost-effective or not. So you need to know how much your healthcare system is willing or able to pay for a unit of health benefit, and what other criteria you might want to think about. So when doing a formalized economic evaluation or decision analysis in a guideline, it's necessary to agree those principles that are going to be used to make those decisions about cost effectiveness. So what's often called a reference case is required. So that needs thinking about what's the perspective for the costing. If you're going to use a cost effectiveness threshold, where should that threshold be? What's affordable for the healthcare system? What is other payers within the community willing to pay for the health benefits? But of course, there are other challenges for doing cost-effectiveness analysis in clinical guidelines. And I think the main distinction with health technology assessment is just the scope of clinical guidelines, the size of the pathway that's often being assessed. And it's very difficult, if not impossible, to formally, quantitatively assess the cost effectiveness of every question that you might be considering in an in a clinical guideline. So that's challenging. Obviously, if you're going to do it, you need people who understand it and can do the sums, and you need data, and you also need a guideline group who are willing and able to take on that task. So some of the key questions that I think have arisen, certainly within the history of trying to look at cost effectiveness within NICE guidelines, are about, if you like, the scope of the analysis. What questions do we do the economic analysis on? Should we focus on one or two key questions where there's a big resource impact and where there's potential for an economic evaluation to add value? Ideally, one might want to take a whole pathway approach and build a model of the whole healthcare pathway that you could then use to address a number of different questions within the guideline. But that's really challenging and realistically not feasible within most kind of guideline development process. So decisions have to be made, prioritization decisions about when to do an economic evaluation. Also decisions about how to do the economic evaluation. So in some situations, a really simple approach might give you what you need to make a decision. So there might be a published analysis that will be close enough to your situation that can give you an answer, and you're happy with the methods that they used. Very often that isn't the case. There might be a simple approach you could use, a simple decision tree, or you might need to use a more complicated model in some situations. And so it's a matter of focusing on where is it worth spending that analytical effort and time. So my conclusions, do costs matter? Well, yes, of course, I think they do. Are clinical guideline developers the right people to think about costs? Well, I think that depends. It depends on the situation, it depends on the willingness, it depends on the availability of resources to be able to look at cost effectiveness in an open and honest and sufficiently robust, technically, way in order to come up with realistic answers. But in order to do that, one has to make judgments about where to focus the effort. Which questions are the resource implications going to be important enough? Where can the economic analysis actually help to resolve uncertainty about that balance between costs and benefits? And where can simple methods be used to give a good enough answer to be able to give you confidence that the recommendations that you're making are likely to be a good use of resources? And where do you need to use a more complicated method to try and weigh up the different sources of information? Okay, thank you.